In this video, we discuss about angioarchitecture of spinal dural fistula, endovascular treatment and long-term outcome. 54-year male presented with progressive weakness of both lower limbs for last 10 months. He was bedridden and incontinent at the time of presentation. He received treatment for dorsal myelitis with intravenous methylprednisolone and plasmapheresis. MRI thoracolumbar spine showed long segment of abnormal T2 hyperintense cord signals. Clue to the diagnosis is prominent vascular signals at dorsal aspect of the cord. MR spinal angiography study showed presence of arteriovenous fistula feeding from hypertrophic right L3 lumbar artery. Fusion MR spinal angiography study showed location of fistula at ventral epidural space behind L4 vertebral body. This is selective right L3 lumbar artery injection that revealed dural fistula between right L4 radicular artery and epidural venous pouch, which is then draining via dilated tortuous ascending intradural veins. In this sketch diagram, we can see the three components of the dural fistula: the radiculomeningeal feeder artery, the epidural venous pouch, and intradural draining vein. The fistula is located at the junction of the feeder artery with the venous pouch, where there is sudden change in the lumen caliber. In this fusion image, we can see right L4 exiting nerve root at the foramina, radicular feeder artery following the nerve root and joining the venous epidural pouch, and we can see intradural draining vein within the spinal canal. We can see the fistula and the venous pouch is located at ventral epidural space. This is the sketch diagram of venous system of spine. Here we can see the extensive internal vertebral venous plexus. The venous plexus and the radicular veins drain via intervertebral vein to the ascending lumbar vein. This is the sketch diagram of our case. Here we can see the dilated venous pouch at epidural space and the fistula between the radicular artery arising from aorta and this venous pouch. Plan for endovascular treatment in this case. Standard tricoaxial technique is used. Squid 18 from Bolt is used as embolic agent. Superselective microcatheter injection showed the flow across the dural fistula and the tip of the microcatheter. An injection of embolic agent. Here we can see that embolic agent has occluded the fistula and is traversing across the midline and occluding the contralateral feeder artery. Embolic agent has occluded ipsilateral feeder artery, venous pouch, draining vein and contralateral feeder artery. This is the 3D reconstruction of the embolic cast, and here we can see that embolic cast resemble the 3D angiogram of dural fistula before treatment. Angiogram showed total occlusion of dural fistula and draining vein. At 3-month follow-up, patient is able to walk without assistance, has gained some urinary control, and there is improvement of sensory level. At 6-month follow-up MR imaging study, the abnormal T2 hyperintense cord signals disappear completely.